to join the meeting. So thank you for everyone who is here in person and virtually. I think we're up to 40 something online virtually as well. Just for a few housekeeping items, this meeting is technically a subgroup of EMS Council, so we do have to follow open meeting laws. So we have shared the agenda ahead of time, but we want to make sure we do introductions as we do need to gather attendance from EMS Council members. What I'll do is first do formal introductions of everyone who's willing to come and help speak at the meeting today. And then Shelley will manage the introduction virtually so that we can capture attendance for EMS Council. So first I wanted to introduce Rachel Garcia. She is the Deputy Assistant Director and Bureau Chief for Bureau of EMS and Trauma Systems. Next, Dr. Lisa Villarreal, who is the CMO for ADHS. Dr. Sarah Salik, who's the CMO for Access. Andrew Irwin, thank you for joining us from the COO for Solari. Battalion Chief Jesus Rivera from Surprise Fire Medical, Assistant Chief Dan Jarrett from Daisy Mountain Fire Medical, and Trina Gallegos from Daisy Mountain Fire Medical as well. So thank you all for being willing to come and join us today and speak at this work group. Shelley, do you want to go around the room and then do the virtual attendance? Yes. Okay, thank you.
I'll start with around the room. I'm Shelley Bissell, the executive clerk for the meeting. Working the bureau. Go ahead.
I'm Sean Walker, Hospital Coordinator over in Australia. Brian Hubble, CON and Rates Program Manager for the Bureau.
Hey, good morning, everyone. My name is Ethan Yanofsky. I'm the Deputy Chief of the Bureau of EMS and Trauma Systems.
Hi, I'm Taylor Pikes. I'm the Section Chief over Ambulance Services.
I'm
Dave
Courtney.
Harden. Dave Harden, Bureau of EMS Strategic Planning and Recognition Programs Manager.
Hey, Dave, we're gonna let all the people online. We're going through the room first.
Oh, okay, sorry.
I'm Courtney. I'm the Assistant Fire Chief of Mesa Fire and Medical over EMS and Transportation Services.
Good morning, everyone. Ray Ochoa, Assistant Chief for Phoenix Fire over Emergency Medical Services.
Paul Weasley, Fire Chief, Goodyear Fire.
Keith Seard. I oversee the Community Assistance Program with the Phoenix Fire Department.
Garth Gamer, I'm on EMS Council and I'm Medical Director for Phoenix Fire, Glendale Fire, Surprise Fire Medical, and Chair of AIMS, the Central Arizona Regional Coordinating Council.
Jesus Rivera, Surprise Fire Medical.
Trina Gallegos, Daisy Mountain Fire Billing Manager.
Dan Jarrett, Assistant Chief, Daisy Mountain Fire Medical.
Marla Rivera, Chief of Crisis for Solari.
Andrew Irwin, Chief Operating Officer at Solari Crisis Services.
Rachel Garcia, Bureau Chief for EMS and Trauma.
Chief Medical Officer for Public Health at ADHS.
Clara Salik, Chief Medical Officer for Arizona Medicaid, otherwise known as Access.
Noreen Adlin, Section Chief for Trauma and Pre-Hospital Coordination here at the Bureau.
Good morning, folks. Dewey Anderson with the Bureau of EMS. I'm a Regional EMS Coordinator.
Now I'm going to read off the names that are listed as attending online. Amber Wright, Amy Devon, Brian Elizco, Brian Smith, Brian Pissany, Brittany Kaufman, Casey Solom, Connie Teague, Conrad Loney, Cynthia Wadier, Dan, David Harden, Debbie Johnson, Eric Cooper, Eugene Lavar, Franco Castro Marin, Glenn Kasperzik, Heather Miller, Jason Dozo, Jason Kaplan, Jennifer Colbert, Jordana Carpenter, Jose Garcia, Josh Gaither, Julia Benton, Margaret Hepburn, Megan McCabe, Michael Riley, Michelle Tavis, I'm sorry if I pronounced that wrong, Neil Thomas, Robin Utah, Rod Reed, Roy Royal, Russell Lindholm, Sandra Espinoza, Sandy Nygaard, Sarah Karate, Scott Benzing, Shari Brand, Shirley Gunther, PJ McKay, Tom Brandhuber, Bob Colchicani, and Vince Martinez. And then we just have joined in the room with, go ahead, Sheila Schoen. Is there anyone on the phone only? Please chime in. All right.
Hi, good morning. This is Todd Harmio.
Thank you.
Thanks, Mark. All right, next slide, please, Shelley.
Here.
All right, so thank you everyone for joining us today. I know this is a topic that has really been kind of talked about for many years, going back at least probably 6 or 7 years, and even before that, as we first started exploring treat and refer as a concept here in Arizona. And we started to see pre-COVID a significant increase in behavioral health emergencies and ED visits really related to different behavioral health complaints across the state. When we had our initial COVID the first year, we know that there was a drop in 911 calls. We also know that there was a drop in ED visit. And we definitely saw that the patient population did not seek care and was not getting access to care during that time frame. However, when things started to normalize, our 911 numbers went back to normal and started to actually increase, as well as emergency department visits. We've seen that a lot of the strains and stressors related to COVID have really increased the number of behavioral health patients. When we look at behavioral health emergencies for EMS, these are often a stressful call for pre-hospital providers. They're a stressful encounter for many emergency department personnel as well. And they really are patients that we often want to try to address kind of a more holistic fashion. The current standard process, I think, across Arizona, as most of you in this room know, is someone calls 911. They've accessed the 911 system for behavioral health emergency. Typically, an EMS crew responds, and that patient is almost always transported to the hospital. When they get to the emergency department, those patients are often there awaiting bed placement. Some of those patients absolutely need medical clearance, and that medical clearance is appropriate and necessary for those individuals to make sure that they're safe and healthy, and there isn't a medical emergency that's causing the behavioral health emergency at this time. But we do know that these holds are really can often take days. Oftentimes, when the patient is cleared, these patients can sit there for hours, days, and depending on certain patient populations, especially when you look at pediatric and geriatric patients, some of these patients will actually hold in the hospital for weeks pending placement in a behavioral health facility. And so we recognize the overall strain to the healthcare system. Next slide, please. So as I mentioned with the strain, in the emergency department, I still kind of have my feet in both sides of the world here. So I still work clinically in the emergency department along with my role here at ADHS. And the thing that I definitely see in the emergency department is really the strain in the ED to the staff. Oftentimes these patients, they require a sitter. There's hold hours. So this really takes up a lot of bed space in the emergency department, which has a trickle down effect. If you've got, 5, 10, 15, 20 behavioral health holds in your ED, those patients are generally in a room. They are often having a one-to-one sitter, so there's a staffing need. There's also a safety component for the patient. But one of the big things we see with these patients is they don't receive psychiatric care while they're holding. And if you think about a patient in a psychiatric emergency, when they're holding in an ED, we aren't really trained to provide that psychiatric care that they need. Really what we're doing is making sure they're medically clear, and we're trying to get them placed somewhere else to get that psychiatric evaluation. So there's a strain to the healthcare system. It really, how that affects the trickle down in the ED. If our beds are full with behavioral health hold, that means when you bring a patient in for a medical emergency, they may be waiting to get offloaded because we don't have a bed to put them in. And so we just start to see the overall effect of that. And then a big component that we see and that we've heard from our stakeholders is that we understand once you then need to transfer the patient, they need a secondary ambulance transport. So once they've come to the ED, they now need to get placed somewhere. Typically that transport is done by ambulance. So this patient is now getting a second ambulance, and we recognize some of the strains of the system. We have had a huge workforce shortage across the entire healthcare system within hospitals. We certainly see that within EMS. A lot of the work and the surveys that we've done through the Bureau of EMS and Trauma System in the last few months is to really try to gather across Arizona, what does our workforce shortage look like? How is that impacting care? And we hear from throughout the state how there's many parts of the state that are having difficulty staffing their units, getting people to apply for positions. Things that used to be thousands of individuals applying for a certain EMS agency job, you now have a much smaller percentage of people applying for the same position. And so we recognize that the shortages then result in less ambulance options to get those patients transported to definitive care. Next slide. So we wanted to cover a few work group goals. We recognize that this is a really big topic. We want to try to keep this a relatively narrow scope and go through kind of a couple slides of goals and what we'd like to do. So one of the things the chief question said, as we're kind of emerging from COVID, what can we do to really address this? We keep hearing from stakeholders the effect that this has across the healthcare system. Is there something that we can do? And so number one, we want to review existing statute and rule as it pertains to alternative destinations. Really make sure that everyone understands what's existing in statute. I think there's a lot of misunderstanding and misinformation, and we thought this was a great opportunity to kind of level set what is already allowed. The next piece is talking about diversion of appropriate patients with behavioral health crisis from the ED. We recognize that some patients are going to still need to go to the emergency department. Many elderly patients may have a medical condition that's causing acute delirium that's making them present with a behavioral health emergency. And other patients who's had an overdose or just are severely agitated may not be appropriate to go directly to behavioral health facilities. But ultimately, our shared goal is to try to divert patients from the ED when possible. Ultimately, we'd like to transport the patient to the right destination the first time. I'll say as an emergency physician, I'm probably not the right person to be taking care of most behavioral health emergencies. I can manage an overdose. I can manage someone who's in acute crisis that's extremely agitated. That's part of my expertise. When it comes to actually providing psychiatric care and treatment, it's really not our expertise in the emergency department. And another part of the goal is to really try to create a sustainable model that is cost effective. We've heard from stakeholders over the last several years some of the barriers for them implementing current programs, and we want to try to figure out how do we make this cost effective and sustainable. Next slide, please. So really key pieces, we're not looking to replace existing infrastructure. We know that a lot of this work is occurring. Thank you to Stellaris for being here to present today. I really felt having had the opportunity to go and hear their presentation of the services they offer and see their dispatch center, that really this is a resource that many within the EMS community and hospital don't really know the breadth of what they do. And so really this is a great opportunity to kind of spread the word of what resources are out there. So we're not looking with this work group to replace existing resources. We also know that law enforcement takes many patients directly to behavioral health facility. We're not trying to change that process either. We recognize that this is just simply an opportunity to augment this. I'll use an example that came up within the last couple of months that was brought to my attention. I was an EMS crew. 911 was called for a patient who was suicidal. They were there as family. They were voluntary, they were calm, they had not attempted any self-harm, they had an overdose. The crew called for crisis response units, and just based on the time of day and volume, it was going to be a little bit of a delay in that response unit getting there. So the crew called their base hospital to say, the patient, we don't want to stay out of service. Would it be possible for us to leave them here with their family? The family is very reliable. We feel comfortable. And the physician gave an order and said, no, you either need to bring the patient in voluntarily or restrain them and bring them in to the ED. And if you think about the dissatisfier to that patient, their family, and to the EMS crew in the hospital, right? Everyone ultimately, the receiving facility was pretty frustrated. The EMS crews felt like, we're trying to get back into service because we know that we need to get back into service. But is there a way we could have managed that differently and better? And so looking to see with these types of scenarios, are there times that we can divert the resources and get that patient to the right place? And really, I think sometimes when you look at these examples, these things happen all the time. This was one where the crew was just frustrated enough that they actually took the time to let their agency know, right? But we know from our EMS providers, many times they just manage situations and they go on with their day. They don't bother, kind of pushing the messaging up. So again, our hope is to augment the system. We're not trying to replace any existing options of how patients get to alternative destinations. And the other key piece that I wanted to keep in mind is we understand that many agencies do alternative destinations for other types of medical conditions, but we recognize that that is much more complex. When we start looking about taking a patient with a medical complaint to an urgent care or different options, we start getting into other complexities like transportation, pre-notification, insurance issues. And so we really want to keep this specific to behavioral health patients and alternative destinations for that. So that is a potential future goal, but just to kind of level set our goal for today to really address the behavioral health population. Next slide. So I will turn over to Chief Garcia. She is going to be the rule expert and kind of go through the next few slides.
Okay, so to really set the stage today, we wanted to give a little bit of background on existing statutes and rules. And we tried to make this a little bit interactive in terms of the typical questions that we receive about the statutes and rules. And so the first question that we have here is, can EMS transport to alternative destinations? And you heard from Dr. Bradley, the answer is yes. Ambulance services can transport to an alternative destination, such as a behavioral health facility or other healthcare institution. And the rule citation is listed there, R925-504B, which also references the Arizona Revised Statute that you see here. If we go to the next slide, this is in detail the rule citation behind alternative destination. And so again, it's 504B, and under A.R.S. 362205D and 362232F, an EMCP who responds to a call made to 911 or a similar public emergency dispatch number may refer, advise, or transport the patient at the scene to a healthcare institution other than a healthcare institution specified in subsection A, if the EMCP determines the following. The patient's condition does not pose an immediate threat to life or limb based on medical directions. The healthcare institution is most appropriate for the patient based on the following: the patient's medical condition, choice of healthcare institution and healthcare provider, the location of the healthcare institution and the emergency medical resources available at the healthcare institution, and determination by the administrative medical director that the healthcare institution is able to accept and capable of treating the patient. Next up on the following slide, the question that we get asked often is, can EMS bill for transport to alternative destination? And the answer here is also yes. We wanted to provide the citation for billing for advanced life support base rate, or the ALS rate. Here we have A.R.S. 362239 that outlines an ambulance service shall charge the ALS rate as prescribed by the director under the following circumstances, providing that the ambulance must be staffed and equipped appropriately and that the patient receives the services or is transported by the ALS unit. If we go on to the next slide, we have the citation for the BLS rate, A.R.S. 362239G, and an ambulance service shall charge the BLS rate as prescribed by the director under the following circumstances, again, when the ambulance is staffed and equipped appropriately and the patient receives basic life support services or is transported by the BLS unit. We could spend a little bit more time talking about these statutes if there are questions as we move along in our discussion today. But really to tee it up, we wanted to make sure that folks knew the statute and rule references behind alternative destinations and billing for ALS and BLS services. We have one more slide that talks and gives the citations to ground ambulance fee schedule and reimbursement. As you all know, ambulance services in a state must have a CON, or certificate of necessity, in order to operate an ambulance and charge for services. That includes the treatment and transport of behavioral health patients when appropriate. And ADHS is responsible for setting that ground ambulance rates and charges or fee schedule in order for the CON holders to bill for services. We've provided a copy of the ADHS ground ambulance fee schedule linked here in this slide. And to complement that, we also wanted to share that under Arizona Revised Statute, we also have Medicaid reimbursement outlined. And so that information is all here to really help us set the stage for the discussion today. I'm hopeful that this can help guide us a bit as we move through the rest of our agenda. And I just want to check in to make sure, Dr. Bradley, do you think we met the marks with those slides setting the stage?
I think so. I think one of the questions I just wrote down to address later, which we will touch on at the end, is one of the things you note is the decision to go to an alternative destination is having that medical direction approval kind of method that you can do that. And we do have kind of a guideline, a draft one to look at the end if we have time. Next slide. All right. We're going to hand over. Thank you.
All right, great. 1 second. Oh, no. Sorry, I think we logged off Google Meet. All right, I'm in.
I can see you on the screen, Andrew. I'll use the box with the up arrow.
Oh, you're good.
How I live my life now. All right, sorry for the delay. So like I said before, my name is Andrew Irwin. I'm the Chief Operating Officer at Solari. I've been with the organization for 10 years, and I oversee all of our day-to-day programs. Marlo is the lady that runs everything hands-on. So when people ask hard questions, she's really our expert.
And just
Yeah. All right. So when we talk about what Solari does, we really have two parts to our company. We have a social determinants of health business that's represented by that green dot, and then we have our crisis services. So we started back in 2007, and we were just the crisis line for Maricopa County, and that was the entire purpose of the organization. Our CEO came in 2014 and was really concerned about the level of individuals that were calling into the line and the possibilities for averting crises. We really started to have a conversation about what is bringing people to this point where they're making that call to us. And a lot of the conversation was around access to behavioral health services, access to housing, access to food. When those basic social determinants of health aren't addressed, we have people that escalate into a crisis that then becomes life or death. So we acquired 211 in 2016. And in case people aren't familiar with that, that's the hotline for health and human services. You can call and talk to a person, and they're going to help navigate you through access to things like housing and food and the behavioral health system. Non-crisis situations, but really the things that help people get put together in terms of addressing resources and keeping them from escalating into those crisis services. Additionally, what it did for us is it also gave us an outlet for the calls that were less acute or could be resolved with a different means, meaning somebody's calling in and they're saying, I have a life or death situation. When we get to the basics of it, we have a mom that's facing losing her home, getting evicted. We have a solution for that. So can we get her connected with 211, talk about access to resources to ensure that she can stay in that house, then taken a crisis situation and been able to resolve it. So conceptually, that's really what the organization is about. We have a whole bunch of programs that fall within these two categories. And I've got a little diagram here. I'm not going to go too far into them just because there's a lot. But in the top left there, you can see we've got our crisis hotline. It's 24/7. We have what's called a peer line. So that is a non-acute hotline where individuals that are isolated or alone can call in. We have a lot of senior citizens that call into that line, people with behavioral health issues. They're able to talk with somebody with lived experience. So they're having an interaction with somebody that's been through the type of things that they've gone through. Like I said before, we've got 211. We operate the SMI evaluation program for the entire state of Arizona. We also operate the housing or the homeless management information system. So folks that are familiar with the shelter system, every piece of data that comes out of those shelters comes to Solari, and then we're able to give that back to the community and talk about what's happened in terms of housing. We operate Maricopa County's Housing Crisis Hotline. We run a Veterans Hotline, and then we also work with DCS on their rapid response assessment. So now I'm just going to move into specifically what the crisis line does and our capabilities. I'm going to talk in general from like perspective of the general public, but then really focus on diversion, which obviously you guys are here to talk about today. It's that one. So when individuals call into the hotline, what we're doing is we're dealing with call to text where they're going to get spoken to by a real person. There is no push button system when they call into our hotline. They immediately talk to somebody. We've got statistics in a couple slides, but we pick up the phone in about 9 seconds. We are not 911, but we really want to be. We're putting as much resources as possible in terms of picking up the phone as quickly as possible and having a response out of a live person. What we do is we collect the individual's name and date of birth, and then we move on to asking them about the acuity of their situation. First 2 questions are about suicidality or potentially harming others. From there, what we're doing is we're going into specifically talking about how do we resolve the situation for those individuals. This is a bit different than the experience that law enforcement or other first responders would have when they call into the hotline. So in a couple slides, I'm going to talk about the volume of calls that we get from law enforcement. That conversation is them asking and identifying themselves as law enforcement and then immediately moving into a dispatch so that they don't have to go through that longer process of a discussion about acuity or what's happening. We directly move into, do you want a mobile team? And then we talk about how quickly we can get a team out to law enforcement. This slide is important because I think there is a connotation nationally that crisis hotlines, suicide hotlines have one purpose, and that means that we have to be super acute. It needs to be life or death. That isn't the way that Arizona has built its crisis hotline. Our crisis hotline has a very wide open door. We want people to call in on the front end before things escalate to try and resolve them before we end up in that acute situation. So these are just a few of the reasons that people call us. So depression, anxiety, all the way up to self-harm. And then we also have people that are just calling in because substance use issues, housing issues, and they're classifying it as a crisis. We let people define the crisis. They call us and then we help resolve it. Not always our job in terms of whether or not that's going to come to us, but we find a solution. Very similar to all first responders. You're presented with a situation. You have to come up with a solution or the next step for those folks. So this is a dashboard that's on our website. Folks can access it on our webpage. What it is it's the statistics as of yesterday of how we're performing over the last 30 days. So we've taken over 38,000 calls. That number has been up to 45,000 in terms of monthly volume. That is one of the busiest crisis systems in the United States. And that is by design. So that is us saying we want this wide open front door for anybody to call into us, and we're going to help resolve that situation on their behalf. Our answer rate is 99%. So within 15 seconds, we're picking up the phone with a live person and speaking to them. Again, that's close to a 911 system. The average speed of answer is 9 seconds. And then 88% of the time, we're stabilizing that call over the phone. So one of the big things that was important to us as we were developing a relationship with first responders is that we're not just pitching these calls over to fire, EMS, or police. We are actually stabilizing these callers over the phone. We're coming up with the resources of the behavioral health system so that we're not having some of the impacts that Dr. Bradley was talking about. We don't want people to go to the ED. We want to funnel them into the behavioral health system that we have established here in Arizona. That's the best course of action for those individuals. So 88% of the time, we are not doing any type of other escalation. The 88% is representing circumstances where we have to send out what we call mobile teams. So those are 2-person teams that will go out and meet with that individual face to face. And about 2% of those are situations where we have circumstances where we cannot make that person safe over the phone. A mobile team would be appropriate. So that's someone with means immediately to cause harm to themselves or others, or circumstances where something has already happened, like people have taken medication that we need to send out first responders immediately. So in those circumstances, we are asking first responders to go out. They make up for about 10 to 12 calls a month. Is that about right?
It's less than 5%.
Less than 5%. Yeah. So vast majority of the calls we're trying to handle on our own through the crisis line. We've got a breakdown on the left there of the reasons that people call us. So social concerns, self-harm, suicidality, coordination of care. What was interesting is that our statistics in terms of what Dr. Bradley said about 911 mirrored that, and that we saw a significant drop off in calls to our hotline during COVID. And then when people came back into the community, we saw those numbers bounce way back up. The other thing that's interesting is that the reason for call historically was always self-harm, suicidality. That was the top reason that people called us. And what we saw as social concerns shifted. To us, that really does speak to some of the trauma and behavioral health issues coming out of COVID, and that those things have escalated into a situation where we're seeing many more calls. Down below in the purple graph, you can see those are our mobile teams. Just in Maricopa County, we have 37 mobile teams running 24/7. This is one of the most complex and most responsive crisis systems in the United States. So in places like New York City, where they have a lot of resources, they can be up to a day to get this type of response that we have in Arizona. For the general public, we're getting a response in 1 hour on average for the month. and it's 30 minutes for first responders. So if a police officer called us, our objective from Access is that we're going to have a response within 30 minutes to those folks. So that for all the reasons that where Dr. Bradley was alluding to in terms of responsiveness, the need to get back in the community and do the services that EMS does. These two. And then finally, in the bottom right corner there, you can see the number of calls that we're taking from law enforcement. So those just represent calls that are coming from officers in the field. So 2,151 calls. We responded with mobile teams about 50% of the time there. So we've been working with law enforcement around the concept of diversion for decades. It's really been something that's been a focus. So part of their CIT training is for us to go out and do this type of education. So every law enforcement officer that's participating in CIT hears about the crisis line in addition to the other training they're doing around behavioral health. And then they utilize this service in the field. They're calling us to say, I have this situation, what's the ETA on a mobile team? And then they can make the choice. Can I leave that person safely? Like the example that Dr. Bradley gave. Is this a situation where I need to pick them up and just bring them to an urgent psychiatric center? Or is this a situation where I have to come up with a different solution? Access has been very deliberate in the concept of we are avoiding the emergency room, we are avoiding jail. Those aren't the responses that we want law enforcement to have to choose. So we're giving them these other options. In terms of that relationship, we understand that speed matters, and it's one of those things where EMS is doing that same type of math from the field about getting back to another call versus having to stay with somebody versus coming up with a solution like dropping somebody off at the emergency room. And so the system has been specifically built, and we've had those conversations with law enforcement to say, use the crisis line, use the mobile teams, use the urgent psychiatric centers. Those are built for you, and we want a custom response just for you. So what I just described there, this is the continuum just laid out to be very clear how Access's crisis system works. We've got the person in crisis, they can contact us through 988 or our 10-digit number. We have the ability to escalate that to a mobile team. If necessary, that mobile team can bring a person into an urgent psychiatric center, and then post-care follow-up happens. One of the best things that happened in Arizona compared to other states is that when a person calls into Solari, there's going to be follow-up from the behavioral health system after the fact to avoid the necessity of them calling again, going back through this exact same system. So every single day when individuals call us, we take the notes from that call and we push it back out to behavioral health teams. So the vast majority of folks that are contacting us are Medicaid enrolled. They have a clinic, they have a behavioral health provider that's overseeing their day-to-day care. And what we're doing is we're connecting those systems together. So you've come into the crisis system. We're then going to notify your provider that that individual called us, they had a mobile team come out, or they went to a facility, and then they're going to get care after the fact with the objective of preventing the situation in the future. This is just to highlight the structure of how our system is built. So SAMHSA is the ones that go out with our 3-digit dialing. So we now have 988 as a way to get quick access to the system. That's funded through that federal program. Access is supplementing at a local level through the REBUs that all have contracts with us. And then we take the calls from there. I just wanted to put this in. 988 is new. There's a lot of information in the news about it. What this really shows is just how much investment Access has put into the system over the years. So only about 10% of our calls are coming through that 3-digit number. The vast majority are aware of our 10-digit numbers and they utilize those services. So this is really built into, law enforcement, to the teams that are already out in the community. People are aware of our numbers. So many, many more calls through our main crisis lines. So I did want to talk just a minute about diversion in terms of how this functions with 911. 2018, we started a program with Phoenix 911 Dispatch Center. What we came in and did is we trained every single dispatcher at 911. It was over 300 individuals. Then what we did is we changed their policies to transfer calls to the hotline. And so the concept behind it was, can we front end issues where the response in the past from 911 is not going to pick EMS fire or I'm going to pick law enforcement, but one of those two are going to get this call. And what we did is we stepped in and said, If there's a certain set of criteria, meaning the person isn't in imminent harm, they're not going to imminently harm someone else, and it is solely a behavioral health issue, you do transfer those calls to us. And so we are now getting around 3,000 calls a month between just about all the major municipalities. So right now we have Phoenix Dispatch, Mesa Dispatch, Tempe Dispatch, Tucson Dispatch. All of them are in the program now, and all of them are transferring calls to our hotline directly. Again, that's us being able to step in and say, we won't even escalate this over to police, fire, or EMS. We can handle it on our own. Of those calls, we're stabilizing 50% of those without any higher level of intervention, meaning that we just took those calls out of the 911 system and we handled it for that person. The rest of those are going to be a response where we're sending out mobile teams. And even in those situations, there's very few times where we're calling out law enforcement, fire, or EMS to support us. So we've really reduced the number of calls by a significant number just by getting those transferred over. I just wanted this to be a part of the slide deck so everyone was aware of the resources. So Teen Lifeline, that's a hotline for kids where kids are answering the call. They're overseen by a clinician. Our warm line's listed there, 211, and then the crisis hotline, which is both 988 and then our Hope. That's it.
Thank you. So I'll open up if anyone has any questions for Andrew and Marla. If you have any questions online as well, please feel free to speak up. We'll have some question and answer time at the end if you think of any other question.
Question, this is David at the Bureau of EMS. How does the Solari work with dementia patients who are having behavioral health issues or vice versa? Is there a criteria for that, or do they go to a different type of facility?
We wouldn't take, the first point of contact for them wouldn't be to take them somewhere. It would be more about completing an assessment or a screening with them. And then more importantly, is to see who else is with them. Having dementia isn't necessarily a crisis event unless they're saying it's a crisis event. So if we have somebody, a neighbor, a family member that is with them and they can let us know that, hey, this is beyond what we can handle at this moment, then we would handle it as a crisis event. Ask if they'd like a mobile team, ask if they need help with petitioning process, ask if there's a safety element there. So we would handle it just like any other phone call. Dementia wouldn't change the fact. What would change the way we handled it is the safety need of that patient. So if they're calling on their own and they're like, I'm really struggling, I'm out in the heat, I'm going to walk into traffic, that's certainly a different issue that we then would have to call in a higher level of care for.
Thank you.
Sure.
I see a hand raised, Shirley, on the phone.
Yeah, I'm not exactly clear on how the access of the Medicaid patients are solely directed to you. Is there some screening process, either when they come through 911 or call you directly?
No, so that's one of the benefits to our system is that it's open to the general public. Anyone can utilize the services through crisis. There is no screening of insurance. So we have funding where we're able to get reimbursement through Medicaid for all the Medicaid members. And then there's a set aside from the legislature to cover everyone else who doesn't fall into Medicaid.
Okay, thank you.
In case there are any other questions, I did want to sort of point out in Dr. Bradley's example, it's, I think, a perfect one where EMS is on scene. They're making the call to a physician. They're looking for support. We've dealt with some of those type of issues at 911 dispatch. There's a liability concern. There's ultimately somebody saying, if I make this choice and something goes wrong while I'm gone, what's the potential consequence? We really worked hard to shift that liability over to Solari. It is what we are meant to do by design. We're supposed to take care of these individuals. We're supposed to be responsive. We can come on to a call with EMS and have a conversation about whether or not we think that that person is safe. And we're willing to say our mobile team has this ETA and we're comfortable taking that call. One of the big things that we've done with 911 dispatch is that we asked the person. We didn't think of that right away. It was actually the dispatchers that started doing it. but we gave them the option as the third option of, would you like a behavioral health intervention as opposed to law enforcement and fire? And people say yes. Like 90% of the time, they say yes. That's the response that I'm looking for. So there is turning it back to the patient and asking them what they want. Do you want to go to the emergency room, or would you like to wait for a mobile team to come, and really letting them participate in the process? It gets complicated at times. You know, if we have an individual that is not well in terms of making decisions, we don't know that they have the capability to do that. But I just want to put that idea out there, and that we're participating in this situation with you all. We want to come up with that same safety solution. We can do that in real time, and we can make it happen quickly. I think the work that we've done with law enforcement over the years has been that give and take, where we're having a conversation about what should our policy be as a community about how we respond to particular circumstances. And then there's just a trust level in terms of, okay, I feel like we can leave this scene, and I'm comfortable that Solari and the mobile teams are going to do what they say they're going to do.
Thank you for addressing that. I think, really that's one of our goals, is to try to get the messaging of all the work that Solari does out to the EMS community. I think it was really eye-opening to me to come down in person and see it. We're trying to get people in person again. Sometimes things that you just read about or share a little snippet, it's actually that in-person encounter that really opens your eyes to kind of all the services that are out there. So thank you for adding that contact. It's very helpful.
I'm just curious what response times are like for your multiple teams.
So for first responders, it's under 30 minutes of the requirement. It all depends on the time of day, and I'm sure you guys are faced with that same type of scenario. During busy times, it can be longer. Other times, it's just happens to be faster because of the location of where we have our team staged and how many are on.
Andrew, where do you stage? Do you kind of bound from between east and west, or?
Yeah, so Taros and Impact make up the majority of our teams. Taros is west and Impact is east. They also have started to position teams at various locations. So I didn't talk about it, but all of our mobile teams have GPS in their systems. We've done analysis on where our calls are coming from. They're probably real similar to where you guys are going. And with that, we've been able to stage teams and reduce our response times. I think another thing worth pointing out is that we've had a really great partnership with Mesa. So Mesa actually, they contributed to having mobile teams that were just built to respond to their first responders. And our average response time was 17 minutes for that group.
Thank you. Dr. Gamer, did you have a question?
Oh, just kind of a gee whiz thing. How many call takers do you have on at any given time? It looks like you take somewhere between 38 and 45,000 calls a month.
Yeah.
Incredible.
We have over 200 on staff, but it's to your question of at any given time, it's always a Wednesday. It's probably that way with you guys too, the way staffing 24/7, but about 36 to 40 agents at one given time.
We have a number of other contracts. So we operate the crisis line for the entire state of Oklahoma. We have contracts where we're the backup centers for 988. So nationally, calls are coming in. If people don't pick up the phone in Kentucky, those calls run to us. And so we're doing a lot of work. So we have over 600 staff at this point.
Two questions. What's the best way for EMS to sort of reach out to you to engage those services? And then two, what sort of medical clearance do you guys either do or do you require upfront to manage those?
Yeah. For first responders, you can call our 10-digit, the REBA number that will get you directly to our staff. 988 is still working out the geolocation issue. So if you have an area code that's in a different state and you call 988, you'll go to that state to get handled. So for you all, and I think also your PSAPs have a hard time doing 3-digit dialing. So you have a direct number to us. First responders are the only class professionals that we will give an ETA to. So if you are considering, gee, this might be a good option for me, you can ask us what the ETA is. And you can just choose not to use that if you don't want to, but at least you'd have an idea. In Dr. Bradley's case, if the ETA was, 30 minutes and this person's well cared for, you might feel comfortable then leaving the scene and saying, okay, we can allow Solari to do that. In terms of medical screening, we don't screen that way. We have a assessment screening. So we're accredited through two different American Association of Suicidality and International Helpline. So they give us guidance on how to screen for safety and behavioral health. So that's what we use. We wouldn't ever use medical screening. And I'm sure you all know if you've called into the hotline yourself, anxiety is so hard for us anyway to use. So any pointers y'all have, we take, but it's a tough one for us to decide whether that's a fire call or it's a behavioral health call for us. So we'll do our anxiety screening the best that we can there, but we may call you out for anxiety when people are staying in short of breath, they can't catch their breath, and they're denying any medications or, overuse of those things.
Just based off that question, I want to say two things. First responders do not use 988. Do not use that. You have to go through a push button system. So use that for hope number that I had up previously. They'll get directly to a person, identify yourself, and then it'll go from there. So no problems on the front end. Gosh, I had a second one that was good. Oh, sure, it was great. The UPC, we don't operate the facility. We don't operate local teams. We just do the phone line. But obviously, I hope everyone knows that the response time in terms of dropping somebody at those facilities, I think it's like under 7 minutes. So if the decision is that I want to go to one of those access points, you're going to be able to get that person out. That has been specifically designed through the partnership with law enforcement. We're keeping statistics on how quickly you can drop a person there. So that is part of the equation in saying, do I drive to the UPC? Do I drive to an ED? Do I let a mobile team have a intervention? So I just wanted to be clear on that is a major resource for you all, assuming that the medical pieces get figured out.
We have a question online.
I guess Chief, we can look at the one in line.
So in that narrow document where we've called medical control or decision trees, at that point, could the crews include Solari into that decision tree? And then would a physician allow us to use that as an option?
I think certainly bringing Solari into that conversation, which I think is probably the opportunity to kind of say, let's, have them engage, because potentially had Solari had the conversation and really get more information, they may have said, no, we don't feel comfortable, or yes, we feel this is something that's appropriate. I think that will help make the physician feel more comfortable in terms of making that determination, understanding that when people call for medical directions, can't speak for who you're going to get and what advice you're going to give. But I think the more information you can provide to that physician who takes that call, the more likely they are to feel comfortable with that decision.
I would say that type of conversation with the physician, a lot of headway that we were able to make was through the CIT program, because all the officers in the field are getting educated on what the capabilities are. It is something that takes time, but we have to build relationships. Sure. We're willing to participate. If you guys say that that's the best way to get physicians on board, we'll do it. So we'll be at the table, we'll come up with a policy and procedure and work through that.
I think we have a question from Dr. Woolrich, and then we'll do one more question after that and keep moving on the agenda and come back to more questions at the end. Dr. Woolrich?
Yeah, thank you. I appreciate the presentation. I'm curious as to, in the work you've done so far, have you been able to track your transports and maybe like inaccurate dispositions? And I'm thinking primarily of the patient who is received in a behavioral health facility, and then in that behavioral health facility, there's an intake where they decide they do want advanced medical clearance, and then it results in a secondary transport. Have you been able to track your dispositions and your accuracy in that regard?
We do track that as a system as a whole. I don't know if Dr. Solider, you have those statistics coming out of the facilities, but I know personally it's extremely low. So when I was talking about our statistics in terms of having to outreach fire and EMT, it is a point of emphasis with access that if we can handle it, we're going to handle it. None of the facilities folks I don't think are on this call, but they always bring up that they take people, they're not supposed to take people with stab wounds, but law enforcement brought them there. They are dealing with the situation, then they're calling EMT. But there is a focus on, we are going to handle this to the degree that we can, and it goes pretty far. So it is not very often where they'll be calling out an ambulance, but for, like those situations. They've told stories about people with bullet wounds being brought in and they're dealing with a psychiatric issue and then dealing with EMT. I'd say that because they're saying law enforcement is told to drop people here and they're going to do that. So they can drop them, deal with it. you go back out into the field. And that type of relationship is really what has been built out of the system.
Thank you.
Thanks. All right, we are going to move on next presentation. So thank you very much to Chief Rivera and Chief Jarrett for being present. One of the things that I asked both of them to come today is these are two agencies that have really been kind of on the forefront of trying to do some of this work. And so I asked them to speak today to give a little bit of background on some of their experiences, some of their success, but also challenges in implementing this. We recognize that part of the goal for this work group is to kind of put forward what has been kind of level setting of, yes, you're allowed to do this, yes, you can build for it. But then how do we operationalize this and what are some of the barriers for reimbursement? So I think Casey, you were going to start and then Dan was going to chime in. So I'll hand it over to you. Thank you.
Yeah, definitely. So we've been using alternate destination since 2015. We really started that program because we also received the certificate of necessity so we can run an ambulance service. We started with one ambulance, and the city is surprised that's not really a lot of ambulances. So we want to make sure we kept it available for 911 emergency transport, and we still had the ability to take patients in crisis to a crisis facility. So that's really when we started the program. We worked together with our medical director, Dr. Gamer. We worked with medical director from our closest behavioral health facility and our medical director from the hospital to make sure that we had a guideline that spoke to what that looks like. Because patients needed to go to a hospital for clearance, what does that look like? You know, do we have the ability to take a patient directly to a mental health facility from a 911 scene? If so, what kind of assessment do we need to do that would be acceptable with our medical directors, and what would be acceptable to the behavioral health facility medical director when we brought them there? So we created the guideline, worked together on that, and then we also partnered with the Health Information Exchange to do follow-up because we were concerned about, well, what if we take them there and then they transfer them out to a hospital for clearance, or we're missing something, or there's something in our assessment that didn't work. So we started doing that. We found very, very good results. We found that patients that were going directly to crisis centers were getting the help they needed the first time, and that they weren't going to an emergency room within 3 days, 7 days, 30 days. And if they did, we found there were reasons like they were in a car accident, they had back pain, so they were transported to a hospital, or some other reason, but not really for the reason that we transported them there. Next slide, please. So this is what the process looked like, really, and it's a whole bunch of, bubbles with a lot of words in it. It's really hard to see in the slides, but really what we wanted to do is make sure that we identified the needs. Like, hey, we have a need in our community. There's a lot of people that are calling 911 that want help. We're transporting them to a hospital. They're leaving against medical advice, and they're calling 911 again, and they want to go to another hospital. And they would do that 2 or 3 times in a day, and the crews would get frustrated, and they knew that we need to do something better for these patients because they're not getting the help they need because the emergency room is not the appropriate place to take care of a behavioral health crisis. So we had to make sure we worked together with everybody, our leadership, our medical directors, make sure that the members understood, our labor group understood what the goal was and how this is going to benefit our community and our organization. So we created the guideline. We had to partner with the facilities because we weren't just going to start showing up. We wanted to make sure they're on board. We wanted to have them included and involved in the guidelines so they could say, yeah, that looks good. We'll accept that. And they can provide us with feedback, changes, anything that we need to do. So we created those relationships, and we started with adults. And then we started getting calls for adolescents, but we couldn't take them to that facility. So we had to build other relationships with other facilities that would take care of adolescents, and then geriatrics and dementia and things like that. So we created and continue to expand beyond the city boundaries to create those relationships. Beyond that, when the treat and refer program came out, we had to establish agreements. So that was part of the requirements of the treat and refer program, that we had an agreement in place, and also became part of the AT3 program later on, which is a Medicare program. We had to train our crews, make sure that everybody understood what the process was, what's it going to look like when they respond, how are they going to identify the emergency, and then how are they going to offer this service? Because really all we did before was, would you like to go to the hospital? And if they don't want to go to a hospital, then it ends up being a refusal. We didn't really have other options in our menu of 911 calls. So we had to talk to our crews and how they're going to talk to the customers on giving them these options. We had to look at the billing code and identify what was available. Treat and refer became available, and then ET3 through Medicare and then Medicaid. So working with our billing company as well to make sure that they identify the appropriate billing codes. So when we transport to these facilities, that we have every opportunity to sustain the service that we're now providing for our community. We wanted to follow up with customers. So we got emails to get feedback to let us know how we did this help them or not? Is it working? You know, we care about the service that we're providing. We also would follow up with the crews to see if they're, you know, what their feedback is. Do you feel like it's working? Is there anything we need to do better? And then also compliance on the electronic patient care records to make sure that the documentation reflects what's going on, that they're doing what we said we would do, and that the patient they transferred to these facilities was appropriate. And also the involvement, the customers, the feedback. So we put all that stuff together and it starts the process again. Is there any other needs that we have? Next slide, please. So this is what our flow chart looks like. These are the options, kind of the algorithm. When somebody calls 911, we get there. If we identify that it's a behavioral emergency, then we are going to determine, is this a crisis situation? Are they a danger to self or others or not? If not, then we refer them to local facilities, to 988, to other options, mobile teams that could come out when there was time. But if it was a crisis, then we would provide them with that option. Hey, we can take you to an emergency room where there may be, you know, you may have to wait, there may be a transfer out, or we can transport you directly to a facility that can get you immediate access to care. You'll talk to somebody right away, and they specialize in what you have going on. And so we would get buy-in, and we would use different things like, so we worked with PD, I mean, that was brought up. We worked with mobile teams. We worked on, created a community medicine vehicle, which is an alternate transportation. We would take them there, and then we also use ambulances. As soon as those billing codes became available, that was now an option for us to sustain that service. And now we have more ambulances. We have 6, and surprise, we're adding more. So those were the options that we get them to the facility. If it's a medical situation with the other options, I know we're going to focus on behavioral health, but when treat and refer and ET3 provided us with the opportunity to provide treatment in place, we could provide them with that service and then refer them to the most appropriate facility or even offer telehealth when it was available. So that's for medical. And then if there's an emergency, then we would transport them to the hospital. Otherwise, it's a high-risk refusal. If there's any questions on these type of situations, hey, is this appropriate, is it not, then we would consult with our medical director. So we started using centralized medical direction because our medical directors understood the guidelines, they understood the process, and we weren't going to speak to a doctor that's in the emergency room that may have a lot of other patients and maybe not understanding, or we're not explaining what we need. So our centralized medical directors would properly understand what our needs were and would help us do what's best for the patient in that situation. Next slide, please. This is an example of billing. So we take out the names. We've got facility A through D. These are just some of the examples. And this is some of the more recent within the past couple of years. I know we've been doing this for a long time, but over the last 3 years, these are some of the numbers, some of the facilities where we've had an invoice, if they were paid or not. So you can see there a total billing for all services, treatment in place, and alternate destination, where we reimburse about 34% of the time. And for transport billing, about 46% of the time. So it's a small percentage. We understand there's always going to be a percent of patients that just, there's no insurance, there's no ability to pay. And we're doing our best to try to work with insurance providers so that they can see the benefits of these services. They can know that the patient's getting help right away and they're not going to an emergency room when they don't need to be going to an emergency room and waiting and utilizing other resources that were not necessary at the time. So this just kind of gives you an idea of where we're at, the services that we're providing, and the fact that there is some reimbursement opportunities through the billing codes that are currently available, ET3 through Medicare. I don't know what's going to happen happen after the end of this year when that program goes away. I don't know if those billing codes will exist or they'll create new billing codes. Medicaid has the ET3 program. I'm hoping that Medicaid continues to provide these billing codes and keep them available because they were early to adopt the treat and refer program. They were one of the first states in the country to adopt the ET3 program and make that available because they saw the benefits to the patients. Next slide, please. This is overall everything we do, treatment and transports to alternate destination combined, 46.26% where we're at with reimbursement. So there's a large piece of the pie that's not getting paid, but we're still working and we still believe in the program. We believe in what's best. Our EMS providers are not insurance experts. They don't really ask the patients what kind of insurance you have to determine what type of service they receive. They just provide emergency service, and it's the same service for everybody. So we continue to follow that model. We work with the insurance companies, and we're continuing to work with our billing company to try to, again, make this a more sustainable program for everybody. So again, I believe in it. We're going to continue to provide this service until something changes or we're told not to. Next slide, please. This is an example of some of the feedback that we've gotten from the surveys. This, just kind of shows you right here. If the service didn't exist, I would have taken an ambulance to the hospital. About half the people said they would. There was a good percentage that were neutral, and some said they wouldn't. So at least half we know here that these patients would have taken an ambulance to a hospital. Now, this isn't specific to behavioral health, but this is specific to treatment in place, transport to alternate destination, and all the services combined that we have. 61 response is what we're able to get in a year, I think in 2021. So sometimes it's kind of hard to get that, but this is one of the ways we're able to obtain that. Next slide, please. And then this question we have here is, were they happy with the care they received from the fire medical team and would they use it again? So we're at 100% people that would use this. Alternative option rather than taking an ambulance to a hospital every time. These are options where they did not take an ambulance to a hospital. They may have taken an ambulance to an alternate destination, they may have taken alternative transport to alternate destination, or they received treatment in place. So 100% I think is pretty good. And so, for us and our leadership, we believe that we're going to keep the program going because it seems to be working for them. Next slide, please. So that's my part of it. This is with the emergency 911 portion. I'm going to turn over to Chief Jarrett and Trina for the interfacility discussion.
Yeah, so certainly a tough act to follow, Chief Rivera and his program and what they're doing. So Davie Mountain, we're a fire district. We service the northern part of Maricopa County in the unincorporated communities, as well as Black Canyon City, which is in Yavapai County. Being that we're a fire district, unincorporated, I would say we're less resourced than maybe some of the cities might be. We do have a facility that's in the very southern tip of our CON service area, a hospital that we do interfacility transports out of. We have not yet taken the plunge into exploring 911 patients in alternative destinations. There's a number of challenges that Surprise has been able to overcome, it looks like. That we haven't quite had the resources to really look at. And I'm certainly happy to talk about what some of those challenges are. On the interfacility side, we've got a number of instances going back over the last couple of years where we have transported interfacility transports. So these are prearranged transports from facility to a behavioral health hospital, psychiatric hospital. And we have had some success with billing of those transports. And so those have been successful. We had one instance where as soon as we got to the psychiatric facility, the patient became involuntary, and our crew was actually locked in that facility for over an hour while they tried to figure out what to do. And that situation puts some hesitancy back into us to just say, hey, we don't quite understand this system and this voluntary and how this flow is actually supposed to work. So that's one of the challenges right there, is just what are the capabilities of the facility? What is a voluntary patient? What does that actually mean? What does the medical clearance side of that actually mean? To look at the 911 just going straight into some of these facilities. But I invited Trina. She's my billing expert. She's our billing manager. So if there's questions on, and I don't know if you just want to run through some of the
Yeah,
cases.
so for the interfacility, for the most part, we don't have any issues with reimbursement, except for there are times when we will get a denial based on prior authorization and not having that. And unfortunately, in a smaller organization, getting a prior authorization, it's just not feasible for us to do. So therefore, the claim gets denied for not having prior auth. And this happens a lot in interfacility, which is kind of counterintuitive. Prior authorization are for things that should happen in the future in a scheduled time. But because it's a non-emergency, there are, commercial plans that require prior authorization. I do have one from IHS that did get denied for not having a prior authorization when we went to a behavioral health facility. We just don't have the resources to do that. These calls a lot of times are happening at, 11 o'clock at night on a Saturday. We don't have people in place to call. The crews can't call for prior auth on these transports. And on Monday morning, to go back and look at these calls and find exactly all the ones that need that prior authorization from an administrative point it's just not something we can accomplish to do. So, and the hospital cannot get a prior authorization on our behalf or on behalf of another provider. So getting rid of prior authorization requirements on non-emergency transports would be extremely beneficial, especially in behavioral health. The other thing I've noted is navigating access with the RDHs and the medical is sometimes a little difficult for us to determine who is the appropriate side. So some people may, example, have Mercy Care Plan medical, but may have REBA on their behavioral health side, and figuring out like this is a medical call versus this is a behavioral health call. So then if it's behavioral health, it has to go to the REBA side. From a biller standpoint, it becomes difficult to determine who is the appropriate payer in those situations. So that's from a billing standpoint, sometimes we have difficulty understanding which is the appropriate access payer. But other than that, interfacility, it's been, we only had really the one, but again, we don't do it on the 911 side as of yes.
Another issue too that we've talked about is when you're billing and the using behavioral health diagnosis codes. In the past, we've had some trouble with those codes getting denied for either medical necessity or what's like the other reason?
So because if you use what's called the S code category in the ICD-10, which are behavioral health codes, a lot of times it will get automatically denied as this is a behavioral health benefit. And there are a lot of tiers especially on the commercial side that don't offer behavioral health coverage always. So, and we're not diagnostics either. So we try and stick to the signs and symptoms codes, which are the R codes in the ICD-10, so altered mentation, emotional liability, and those kinds of things. But we still kind of run into issues in the billing process as far as the coding. And, of course, we want to be careful not to apply an incorrect code. But we're also relying on crews who are not, behavioral health specialists. And so it's sometimes a little difficult to assign the most appropriate code without running into snags in the claims process.
So, and we do see that too from denials, like medically necessary that it takes an ambulance to move this patient to this facility for a behavioral health thing. We'll often hear, she'll get phone calls. Why am I getting a bill for this? I was sitting in the emergency room. I offered to drive, or I offered my family to drive me here, and the doctor wouldn't let me go. It had to be an ambulance, right? And so we're having to answer those questions. And, I think that some of the payers are having those same questions. Why did they take an ambulance to?
Right, because we're the most expensive method of travel. Even in a non-emergency, we are going to be the most expensive. And so are we establishing reasonableness? So does the patient really need an ambulance with that level of care in the back of the ambulance to get to the alternate destination? Or could they go by a wheelchair van or some other method? Because again, we are the most expensive. So the payers, especially with Medicare, they're gonna look at that, you know, with a lot of scrutiny. Like, do they really need the ambulance, or could other methods been more appropriate?
Thank you. I think you started addressing a few of the stakeholder questions that we have, but before we switch over to those, are there any specific questions for Jesus or Dan or Trina? Otherwise, we'll go to some of the questions that have kind of been pushed forward to address. Nothing online. Pardon? Nothing online. Okay, so I think the first question that we got was, is there a statewide list of facilities that will receive patients directly from EMS? So I think that is one of the questions. So I don't know, Dr. Sally, if you can address that.
Yeah, happy to. And Hilary, Andrew spoke to this as well. And I shared the list, but it's our crisis stabilization facilities. And so we've actually have that Google map on our website. And so we've got both by adult as well as child. And again, these are crisis stabilization facilities. I also just wanted to know, and this goes back to relationships, Deputy Chief Rivera had just mentioned around those local partnerships with facilities and hospitals, that's the other way, ultimately, when you develop those relationships and agreements, that you're going to do that direct, transport to that facility, within access policy around Arizona Medicaid policy. That's also appropriate around our ET3 program that Deputy Chief Rivera had mentioned. Thank you. Yep. Happy to move on to the next one. I think one slide back. There we go. Okay. And so I think pretty much answered that second bullet. As far as EMS getting reimbursed, Deputy Chief Rivera also described that reimbursement, including, starting back in 2016, we did the treat and refer program similar to Medicare. And then in 2021, similar to Medicare, we adopted that T3. And so we have a plethora of reading materials in regards to how to become, how to be able to get reimbursed as an ET3 provider. I'm happy to send that information out. And so specific to ET3, you do have to have the certificate of necessity, the CON from DHS, with the exception of our tribal partners, as long as they attest to meeting the CON standards. And then the next question around medical necessity, and this is what I was hearing, including from Trina, just in regards to, the bifurcated system historically versus in Medicaid. We've really, since 2000, even prior to 2018, but 2018 was when we did some significant changes to implementing integrated care, including at the payer level. So you should see less and less, at least on the Medicaid side, of the pointing fingers, this is a behavioral health benefit versus this is a physical health benefit. But the thing that stood out for me is around prior authorization. And so if it is an emergency behavioral health need, right? Because I think when we think from an EMS standpoint, is it emergency medical? But I look at it as emergency behavioral health, meaning are they DTS, are they DTO? And so if it is an emergency behavioral health condition, that should not require prior authorization. And so that's something to keep in mind. I think it's the real issue is gonna be around the details of the situations you're faced with, and if it's commercial side versus the Medicaid side, but happy to dialogue further around that. And then if we can go to the next slide.
Yeah, and so as far as EMS, Access does have specific rates established. We actually have to follow the DHS established ambulance rate for that ALS, BLS, and there's a certain percentage based on statute that we reimburse. And when it comes to ET3, there's a specific modifier that needs to be billed. And so we have all those standards in our Access medical policies, including our frequently asked questions. Happy to share those. And then as far as historical treatment refer rate, we do have a rate established. Happy to entertain a conversation related to that, but do want to note that we have moved forward from 2016 with the treat and refer to the ET3 model as of 2021. And I think those rates, I've not heard any concerns around those ET3 rates, but happy to entertain any questions.
I have a question. So you talked about ET3. My understanding is that that was a Medicare program that has since been sort of pulled back. Is that something that the state's looking to continue just at the state level?
We have not, as far as we have not made any decisions in either direction. And so we have permission from CMS to continue the ET3. And so we'll continue to work within Arizona partners to see if it in fact is a benefit to the state versus not. So no decision has been made specific to the Medicaid component of ET3 in Arizona.
And just to clarify, to make sure, there is still the opportunity for agencies that aren't participating in ET3, because ET3 has a lot more options besides just behavioral health, that you can still take down alternative destination and bill at the ALS or BLS rate. So even with ET3 kind of getting sunsetted at a federal level and still kind of, up for decision statewide, there still is an option within Arizona.
Isn't that certain to persist after December when the ET3 program officially sunsets?
Within Medicare, as far as ET3 officially sunsetting within Medicare. And so I would just differentiate around like our flexibilities as a state Medicaid agency versus Medicare. So even though they're both under the umbrella of the Centers for Medicare and Medicaid Services, we run our own Medicaid program here in the state. And so we can determine based on outcome evaluation if it's similar and we have concerns similar to Medicare or not. Because Medicaid is not Medicare.
So if I can speak on that, one of the things that we've talked about internally at our agency, the program like that, that if you have a specific payer group that provides benefit for that very specific service, right? To look at an alternative destination transport, is that something that we would provide to everybody, just knowing, hey, we're only probably going to get reimbursement on this smaller payer group of that, versus we sit there on scene and say, okay, can I see your coverage first before we decide if we can transport you or not? So that is something internally we haven't figured out yet how we would handle that. So that is a challenge.
For an agency that wants to get past the hurdle of proclaiming medical necessity for a transport to an alternative destination, it's the medical necessity of that. You mentioned that it's an emergency behavioral health condition. There are certain things that need to be documented that we assess. It probably the documentation details is what's going to be important for an agency who would pursue this sort of program, correct? Like you have to document not actively suicidal or homicidal, not in delirium, so to speak, or you don't have criteria for those, not suspecting a severe lethal overdose. Those sorts of things have to be probably in documentation, but if you document those, would it stand the retrospective review of paying for such a transport? See what I'm getting at is, if it's access through 911 or similar number, you'd think that would be enough for our teams. But how can we best document these? What are the documentation hurdles that you would recommend?
Yeah, I think probably looking at the details around the specific situations and not the alternative destinations that you are transporting to other than ERs to see. And so I probably think a few case examples would be helpful to dig into to understand, because at the end of the day, when you are when someone is suicidal, and we leverage Solari, for example, and we're utilizing an alternative destination such as our crisis stabilization unit, which is able to address behavioral health emergency. And so I think a lot of it, as far as we use a lot of lingo within our own fields, whether it be fire, EMS, but the health insurance field also uses a lot of lingo. So I'm wondering if in those alternative destinations, as far as you're transporting, where is that as far as what are those alternative destinations? Does it include our crisis stabilization units because of acute suicidal ideation? And on that side, then that would be considered emergency behavioral health condition. But I'm happy to walk through if there are other examples. And then in regards to we don't oversee for Medicaid, we don't oversee the commercial field, but there are specific requirements, and Department of Insurance would be potentially a good partner for us to bring to the table as far as on the commercial insurance industry here in Arizona.
Thank you. So I think in the interest of time, since we have just a few minutes, one of the last questions was really looking at a universal screening guideline. As you mentioned, there has been some work that has been done on this, that has been done kind of regionally more in Maricopa County, that the state did adopt and adjust as well. That really looked to create kind of a universal screening guideline. This is something that, as we have further conversation, we can look to see, does the group want to take this to our standing and statutory committees? If you go to the next slide, please, Shelley. To kind of really look at and make available kind of a universal screen that we know that everyone has kind of had some type of medical evaluation. Again, we want to avoid the scenario where we have someone who has had an acute ingestion or really abnormal vital sign. Again, making sure that we're doing our due diligence. So this is kind of the format that we have matches our TTTGs, which are statewide EMS guidelines. And this is what we have currently up there as an option. So this is something that moving forward, we can certainly look to kind of readdress and implement if the group would like to do this at a statewide level. I think, getting feedback from some of the behavioral health facilities, do these criteria still work for you? Are these cutoffs for vital signs, blood sugar levels, et cetera? We recognize that there's certain patient populations, such as pregnancy, that can make a patient a little bit more difficult to place. So really just making sure that we probably have this evaluated by our stakeholders who could potentially be receiving these patients, and making sure that there's a kind of an appropriate patient population for them. In regards to next steps, it sounds like we are kind of at the end of our time here. Shelley, thank you for switching back and forth. That guideline does not transfer well into a horizontal format. We have to switch to a different one. It sounds like we definitely have an opportunity to potentially reconvene for a second meeting. And I love the suggestion of bringing in the Department of Insurance and potentially getting some of our other payers at the table to see how can we really move this forward. I think the big thing we've brought forward today is the ability to do that, looking to see what other resources are available through Solari and the crisis network throughout the state and 988, and then really having that partnership, trying to model a lot of what's occurred with law enforcement and really try to implement that in a pre-hospital setting for EMS. Any further questions from anyone online or in the room? I see Jason online.
Yeah, hi. So a couple of questions. We flashed up a map of behavioral health facilities, but I'm still not sure on the definition of that. Where are these places that they're accepting these patients directly?
There, Dr. Kaplan, there are crisis stabilization units, such as Community Bridges, Connection. And so if happy to share with you directly the links to the Google Maps.
Is the UPC included in that?
Exactly.
Okay. So then I have more questions. So what is happening currently is when a patient, well, that would be involuntary, I suppose. So if we're sending voluntary patients to UPC, are we not worried that this is going to create a greater backlog for the involuntary patients that are sitting in our emergency rooms?
We can definitely have We can definitely have that dialogue, Dr. Kaplan.
Okay, and then also these facilities, the crisis stabilization facilities, if the patient requires inpatient psychiatric admission after that, where are they getting their medical clearance for level 1 inpatient psychiatric admission?
Yeah, so as far as if they're going to and I know we're at 11:30 and I actually have an 11:30, but if you want to dig in with me, Dr. Kaplan, I'm happy to schedule a separate meeting with you.
Okay. How would I arrange that?
I can, I think you saw my contact information. This is Sarah. We've worked together before.
Oh, hi, Sarah. Yeah, okay.
That would be good to have, if we're gonna have a following meeting, I would love to hear that conversation.
Sounds great.
Because it helps us to make decisions from the pre-hospital EMS side as to whether we certainly don't like our patients getting a second transport bill. So I would love to hear that follow-up as well.
Great. Yeah, no, it sounds, I think we have plenty of work cut out for us, right? And I want to definitely commend, the partners in the room, including Solari. But I think the themes are around how do we best, triage and utilize finite resources across our entire continuum of care, not only specific to EMS, but also our behavioral health resources too, because those are finite. So
thank you very much.
Absolutely.
We will be sharing some of the ADHS slides. We'll just do some cleanup and make sure that gets out to the meeting distribution list as well.
Yeah, I can send them over to Michelle.
Excellent, thank you. And I'll just share Solari's slides too. Well, thank you everyone for participating today. We appreciate you being here in person and virtually, and we look forward to reconvening again soon. Thank you. Thank you.